Hello, everyone, and welcome. I'm Lee Yates, co-facilitator of the TBC at UBC Network and clinical associate professor in UBC's midwifery program in the Department of Family Practice within the Faculty of Medicine. Today, I'm joined by Christy Newton, my TBC at UBC Network co-facilitator. Christy is the Associate Vice President Health and also Associate Professor in the Department of Family Practice in the Faculty of Medicine at UBC. Thanks for joining us today. Before we start, I'd like to acknowledge that the UBC Vancouver Point Grey campus is located on the traditional, ancestral, and unceded territory of the Musqueam peoples, and the UBC Okanagan campus is located on the traditional, ancestral, and unceded territory of the Silk Okanagan Nation. I'd also like to recognize that UBC's activities take place on Indigenous lands throughout British Columbia and beyond, and that you are joining us today from many places. I'm grateful to the traditional owners and caretakers of these lands, and I'm joining today from the unceded territory of the Coast Salish peoples, the Musqueam, Squamish, and Tsleil-Waututh nations. Please feel free to share the lands from which you are attending in the chat.
Thanks, Lee, for that land acknowledgement. And thank you all for joining us today. The TBC at UBC Network is supported by UBC Health, which works under the Office of the Vice President Health. And the overall aim of UBC Health is to help address complex challenges affecting the health and well-being of individuals, communities, and societies. UBC Health facilitates collaborations across disciplines at UBC, across faculties, with external partners and communities to improve the ways we train people, develop knowledge, and shape policy to ultimately address inequities and improve the system and foster and support health. The TPC at UBC Network brings together health professionals, patients and community members, academics, administrators, and policymakers to share questions and ideas important for team-based care in British Columbia. And the network aims to support and complement province-wide efforts to enhance team-based care in British Columbia by focusing on education, research, evaluation, and knowledge translation, and by enabling participants to learn from each other, to connect, and to align their efforts to improve healthcare in British Columbia.
Thanks, Christy. We have a full and engaging presentation and dialogue today, but before we get started, I'd like to ask everyone to take a moment to let us know which perspective you bring to the conversation today. Faculty, staff, student, health professional. Do you represent or bring a perspective from a health professional association, health authority, patient or community member or community organization, researcher? Or do you find your perspective outside of these categories? I'm going to nudge a little bit more. We've got about 70 people with us, and it looks like only about 15 maybe have responded. I don't know if everyone can see the results. It looks like we have some UBC faculty with us today, some staff, a number of health professionals and clinicians, and folks bringing perspectives from health authorities, health administration, and government. Oh, it looks like the pop-up might have closed pretty quickly. Apologies for that. Is it back open here? Looks like it might have been reset. Here we go. We'll try again. Excellent. So we have faculty and staff from UBC with us, a good number of clinicians, some folks from health professional associations, and our largest group today is from health authorities or health administrators and government joining us. We've also got some patients and community members and researchers in the room, and 4 people bringing different perspectives, not in these categories, 5 people. Thank you for taking the time to do that, folks. Okay, this brings us to our presentation. This session will explore the evolution and impact of the Team-Based Primary Care Learning Centers, the TPCLC initiative in British Columbia, which was launched in 2022 to address healthcare challenges and has continued to evolve since. We're very much looking forward to this presentation in just a moment. Today's session format will start with a presentation from the TPCLC team, and then we'll transition to smaller group discussions focused on the following 3 areas: research, practice, and learning. After the small group discussions, we'll come back together here in the main room as a large group at the end to share highlights from each of the breakout rooms and talk about how to continue these conversations going forward. So without further ado, I'd like to warmly welcome the TPCLC team, and thank you for joining us today.
Thank you. I'm just going to share our screen here so we can start our presentation. Okay. Can everybody see?
That's great. Thanks, Jackie.
Okay. I'll just
Excellent.
Go ahead, Mark.
Great. So hi, everybody. My name is Mark McKenzie. I'm a family physician in Chilliwack, BC, in beautiful unceded and ancestral Stolo territory. I've been involved in the TPCLC project since its inception, and we've got the whole organizing and planning team here today. We're really excited about sharing our experience with the TPCLC project with you today, and our hopes for the future of this project. And we're also really looking forward to the breakout sessions where we can hear your perspectives on your own experience with team-based care and team-based care learning, and also feedback on the presentation and the project. Next slide, please, Jeff. So for the agenda today, we're going to do a high-level overview of the project, go over the evolution of the TPCLC over the course of its 3-year project, talk about faculty development and the role it plays in this project, creating a community of practice that's really focusing on enhancing team-based care learning. Also talk about the evaluation piece that's been embedded in this project right from before we launched, and how helpful that has been in reevaluating how we're doing, seeing if we're on track, and I think at this juncture, most importantly, setting us up, I think, in a really good way for next steps with hopefully the next iteration of the project. And this is a picture of the Kimberley Health Clinic. This is one of our TPCLC clinics, and it's in Kimberley, BC. It's got several healthcare professionals in different fields working at this clinic, and also learners from various health professional fields as well. Next slide, please. So TPCLC, the project is all about finding a way for UBC Family Medicine Residency Program to contribute to the growth of team-based care in the province of BC. And the way we went about doing that was recruiting clinics among our network of teaching clinics all over the province. We've got well over 200 spread over the entire province. And leveraging those existing relationships, looking for clinics that were already engaged in team-based care or had primary care network approval to move in that direction, and we're already teaching clinics. And leveraging those clinics with specific funding and support so that they could make team-based care a more kind of conspicuous element of the learning environment for residents. We're really excited at how the project has unfolded. We've been able to create interprofessional learning opportunities, which has been a really cool thing to see grow in the space of the 3-year project. And we're hoping to see this as a focus for our next iteration. We feel the project really helps support longitudinal primary care needs within the communities of BC. And we think that because if residents are training in team-based care environments, we really feel that they'll be more comfortable and motivated to seek out those clinic contexts when they graduate. And we also have focused on helping preceptors balance their teaching, their clinical duties, and their own engagement with team-based care with the specific funding that we're providing. So we've got funding for clinic leadership, for admin support. We've got some money for material upgrades if that's necessary. But the most important part of the funding, I think, is the direct observation piece. We pay for protected time so the resident and preceptor can have their clinical time protected, and we can provide for direct observation and assessment. And that's been a very popular part of the project, both from preceptor and resident perspective. Next slide, please. So we've got 16 clinics or clinic clusters spread over all of BC, with the exception of the north. And this was an interesting challenge we had with launching version 1.0. It was pretty clear that there were elements of the model that weren't resonating with our northern teaching clinics, and it was pretty hard to get recruitment from the north. We did a lot of active listening, a lot of inquiry and reflection and discussion. And I'm happy to report that with those lessons learned, we have 2 very robust team-based care clinics in rural northern BC that are very keen to join our project if and when funding is approved for version 2.0 in July of this year. The distinction between 1.0 and 1.5 clinics, we had 4 very early adopters that were joined up before the remainder of the cohort. And the project was only for 3 years. So we were able to extend their attachment to the project by making them 1.5 clinics. And we also recruited 2 new clinics as 1.5 clinics halfway through the project. And the opportunity we had in creating this kind of sub-cohort within the project cohort was that we could tweak the expectations just a little bit. And what we've asked is for those 1.5 clinics to look for opportunities where we can actually create and track interprofessional teaching and learning. Next slide, please. So TPCLC 1.0, or as my kids would say, the OG TPCLC, was launched in January of 2022. 4.2 million came from the Ministry of Health via UBC Postgrad Medical Education, and UBC PGME oversees the project. It's managed by the Department of Family Medicine and the residency program. It's very much a family medicine postgraduate education project. And so the goals and outcomes and evaluations are all relevant to family medicine postgrad. One thing we were really excited about was we knew we had this really extensive network of teaching clinics across the province. And we thought if we put in extra supports and resources for some of those clinics, we'd be able to be a bit of an agent of change in terms of moving those clinics in a faster way towards team-based care. And this is a picture of the Grow Health Family Practice Clinic in Victoria. They were very enthusiastic early adopters of 1.0 and now are one of our 1.5 clinics. Next slide, please. So the funding model follows the resident in the TPCLC, and it can sit on top of whatever else is happening at that clinic in terms of teaching compensation or clinical care compensation. And that's been one of the strengths of the model, is its flexibility. To calculate the funding that follows the resident, we look at what's called the resident FTE, and that's essentially the resident full-time equivalent or footprint at the clinic. And we look at 8 months of essentially full-time presence of a resident as one FTE. That can be made up of one resident, but it can also be, for example, 4 residents for 2 months each, or two residents for 4 months each. As you can see, most of our TPCLCs are quite small in size, and as a result, they have small numbers of resident FTEs. But as clinic sizes increase, the resident footprint and FTE increases, and that means that as the clinics are bigger, they get more funding from the project. This is a picture of St. Luke's Family Practice in Langley, the very first clinic to jump on board with the TPCLC. They've been a really amazing partner in the project, and they're now one of our 1.5 clinics. And one of the really cool things is with that added expectation in 1.5 of having interprofessional learning, Dr. Flora Wong, who's second from the left there, she started engaging in discussion with nursing programs in her area, looking at ways that her clinic could bring in nursing students into her clinic. So I think this is a really cool example of how the TPCLC project has been able to be kind of a catalyst for those grassroots collaborations and working towards team-based care learning at a very kind of local level. Next slide, please. We've had a lot of residents go through this project. We've had basically 100 a year. You'll see there's a bit of a contraction in 23-24. That's because we had one clinic cluster withdraw, one cluster contract, and one clinic withdraw. So 3 withdrawals from our original cohort of about 19. We learned a lot of lessons through that process, and I think we're much better positioned in moving forward with 2.0 as a result of that experience. We also were able to recoup some funding, and that's how we were able to fund the 1.5 project. Lots of family practice preceptors engaged in this project, as you can see, and providing over 7,000 hours of direct observation, which is really phenomenal. And as I said before, that direct observation piece is consistently reported as a real strength of the project. Faculty development has been highly subscribed and very effective. It's been very cool to see the community of practice that's evolved over the course of the project. And a lot of that faculty development has had a focus on team-based care and team-based care learning, which is pretty neat. And there's a picture of the Kimberley Health Clinic again. Next slide, please. So the 1.5 model, as I said, it was 4 of our early adopters that we were able to extend funding for, as well as 2 newly recruited clinics in Chilliwack and Vancouver Island. So 6 altogether, and very much the same kind of expectations that apply to 1.0. And this is Langley City Family Practice, which has been a very effective and enthusiastic participant in the project since very early days. Next slide, please. The one tweak to the expectations for folks involved in 1.5 is that we have asked for these clinics to be creative in building opportunities for interprofessional learning. So for example, trying to find opportunities for a family practice preceptor to spend half a day working with a nursing student or a nurse practitioner student, and similarly finding opportunities for a nurse practitioner or a nurse in practice to be able to work directly with a family practice resident. The core educational experience that happens at the clinic is still very much between the family medicine preceptor and resident, but we're trying to build those opportunities for interprofessional learning, track those, assess those, and we're hoping that that experience sets us up well for moving into version 2.0, where that interprofessional learning will be more intentional and regular. One thing that's kind of cool about the 1.5 model is it came on board halfway through the project, and by then there was a certain awareness with folks who are also engaged in team-based care about the project. So we've had some cool collaborations that we've been able to connect with the 1.5 model. UBC CPD is working with the 1.5 clinics to create a team-based care CPD curriculum. And Doctors of BC Practice Improvement Program is helping us look at patient experience, specifically patient experience working with residents that are in these kind of clinics. Next slide, please. So 2.0, we're really hoping that we will be able to extend this project and renew our funding. We're hoping we can start in July 2025 when the current project sundowns. Our plan is to scale all those successful elements of 1.0 and 1.5 and roll over most of our existing clinics, and also expand by about 7 clinics with a target number of 25. As I mentioned before, we're really excited about clinic involvement in the north. We've got a clinic in Chetwynd and a clinic in Tumbler Ridge that are waiting for the word. And we've got other clinics on the Lower Mainland and on Vancouver Island that are also interested in joining. So I think with that 25 number, we will have a really comprehensive network of these clinics across the province and well positioned to potentially partner with other folks in the team-based care space. We're also looking forward to having discussion with folks from Indigenous communities where there are already clinical learners and seeing if there's anything about our project that could help those folks in sustaining and growing team-based care in their communities. Next slide, please. So the basic evolution of the TPCLCs, we had version 1.0 where family medicine teaching was pretty much exclusively preceptor to resident, but it was immersed in a team-based environment, and that was an expectation of all clinics enrolling, was that they would be a team-based clinic. In 1.5, we were able to move that interprofessional learning needle a bit and ask clinics to create opportunities for episodic, intermittent, interprofessional teaching and learning. And by extension, we're really hoping to learn a lot by what that is looking like. And then in 2.0, the plan is to have, again, the core teaching between family medicine preceptors and their residents, but have intentional, scheduled, and regular interprofessional teaching and learning as well. So I hope that's been a helpful overview. I'm going to hand over now to Jackie and Christy to talk about faculty development.
Thank you, Mark. So one of the things about faculty development for the TPCLC was this idea of creating something new, something really different. And so Christy and I spent a considerable amount of time discussing what this would look like on the ground and how we can really bring together a community of practice. And what that means is this sort of organic coming together of people with similar intentions and motivations around topics of interest. And so we wanted to certainly develop that teaching quality and confidence around team-based care and around team-based learning and what that looks like. And part of that process was to bring in other groups. So for example, we brought in the Innovation Support Unit group, and they did a wonderful exercise at the beginning that really focused in on patient mapping and what it looks like to work around one patient. And then furthering that by integrating a learner in that. So how do we incorporate a learner in delivering that standard of care? In addition to promoting resources and resource sharing, as well as getting them around the idea of working with a learner in difficulty. So when you're a clinic and you automatically know you're getting a learner in difficulty, how do you orient them? How do you deliver an educational experience with the understanding that there may be stops and flows within that process of their learning and within the process of your clinic's organization and patient operations. So that's been a real challenge, but being responsive to our faculty and our and the ideas that they generate has been really fruitful for us in developing new content. one of the innovations that actually came out of this was this idea that Mark had about bringing somebody in on the ground to help support learning and support that teaching dynamic. Because sometimes as an educator and as a learner, there's things going on. There's minute things that you may not pick up on. And so having a third party in there, somebody more objective that can, one, really directly observe what's happening in clinic time, and two, which we know is really important in our feedback process, is that it's timely and constructive. It doesn't help to get feedback 2 weeks, a year later. You need that feedback now as to how you're going to change things. And Dr. Dick is really important in facilitating that team dynamic, but also supporting it. So supporting it around learners in difficulty, as well as any challenges that preceptors are having in regards to working with them and progressing them through the program, and team building. So often when he meets with the clinic teams, he will provide lunch with them, and it's a great opportunity for him to build the team within a formal space, but also informally, because as we often know, you can have that formal sense of flow of what it means to be a team, and have your clinic work really well together. But then there's that informal aspect. It's that time around lunch, which is also really important in how people talk to each other, communicate, and build that rapport outside the clinic space. So I will now hand off to Penny Cooper, who will go into our project evaluation.
Thanks, Jackie. By way of context, I'm with the Evaluation Studies Unit, which is embedded in the Faculty of Medicine, so it sits outside of the Department of Family Practice, and we, since the beginning, as Mark mentioned, have been supporting this project. So my role in the project, I'm the evaluator. I'm responsible for designing and implementation and reporting back on the findings. But I think one of the most interesting things from our point of view, and important things about this evaluation is that I was embedded, evaluation, and then me through ESU was embedded in the evaluation or in the project right from the very beginning, like before, when we were still in the proposal stage. And what that allowed us to do was we were able to build, well, how are we going to define our success, build that in from the beginning, and have some ideas about how we were actually going to measure that rather than coming in retrospectively, which is what often happens. So we were able to adopt a developmental approach to the evaluation. And what that means is in the first year, when we were still, we were started with one clinic, and then it was 5, and then the full the rest of the clinics mostly joined about 6 months later. But we were able to collect data decide what we were going to collect data in real time, and then feed that back very quickly through feedback loops into the project operations team, and to actually make adjustments as we went that really helped us to adapt quickly as needed, rather than waiting until the end of the first year to find out what had happened. So that was really helpful. The evaluation scope, there are many interested parties in this work, and so the evaluation really takes account of what do the key interest holders need to know. So it's the clinic, it's the preceptors, it's the clinic leads, the Department of Family Practice, the larger PG program, and ultimately the Ministry of Health. Through its funding of this project. So we've tried to build the evaluation in a way to answer all of the questions that our various interest holders have. So the data sources that we have include administrative records, participant surveys, interviews. We've tried a few different things. The most important thing I want to say there is that because we came in at the beginning, we were able to really build as the project was figuring out, well, how are we going to make sure there's accountability with the clinics for the use of the funds? We were able to build the tools together so that they met the needs administratively, and they met the needs for evaluation as well, without overburdening the different groups of people that needed to provide reporting data. So we were able to really streamline what we were asking. Next slide, please. So just super quickly, the key findings, as Mark said earlier, we have been able to use the evaluation results, not just the evaluation, lots of learnings, informal learnings along the way, to define what the evolution from 1.5 and hopefully to 2.0 as well. But again, like having the evaluator in from the project inception is really helpful. We found really importantly that for the preceptors to participate, one of the big hooks in this was they were getting paid for teaching, paid for providing direct observation. And we heard really early on, really clearly that the payment for direct observation really helped the preceptors to feel like they were valued, that teaching was valued. And so we were able to, so that was part of it. But then we were able to bring them into, it was in the team-based setting as well. What was interesting was that people weren't necessarily being very focused about. It's like there was an assumption earlier on that if we expose residents, if we just immerse them in the team-based care environment, therefore they will learn about it. And so there was an assumption that that would happen. And as we have learned, we need to do more than that in terms of trying to make it this learning and teaching much more deliberate. And that's what we've done in 1.5. And hopefully in 2.0 as well, to make those links happen more. So at the clinic point of view, the residents do find the team-based experience very rewarding, which is what we hope for. And the preceptors we found really greatly increase the satisfaction with their teaching roles as a result of participation in the clinic. And you can see from the quote on the right, there are multiple benefits that the residents are noticing. So last two things, we are absolutely carrying on with enhancing these strategies to promote deliberate and focused teaching in team-based care in multiple ways, both formally and informally, and for example, through continued faculty development. And we are absolutely taking that idea of sustaining the preceptor compensation for direct observation in version 2.0 so that we can carry on with the supporting the teaching, but also engaging them in promoting the team-based care and team-based learning. Next slide, please.
So that is the presentation for you folks. I hope that's been helpful. We're really looking forward to hearing from all of you in the breakout rooms. We know that many of you here today are involved in other team-based care ventures and projects across the province, and we're really looking to the future and how our project and the breadth and distribution of our clinics may be able to partner and collaborate with other work that folks are doing in this area. We know that the Gateway Clinic is going to be becoming a reality at UBC campus, and I think there's lots of exciting potential there for innovations and best practice that comes out of Gateway potentially being scaled and distributed through the TPCLC network. So lots of exciting stuff to talk about in the breakout room, and I'll wait till we all get zoomed out into our appropriate spots.
Great. Thanks, Mark and Jackie and Penny and the entire TPCLC team. It's been really interesting hearing about your work and how it's evolved and where it hopes to go. So now, as Mark said, we'll have an opportunity to dive a little deeper with some panelists, and you can see the list of breakout rooms. Because of the size of the group, we added an extra one. So a backup practice group is actually Lee Yates and I. And I'll put on my TPCLC hat as both a preceptor in one of the clinics and also the faculty developer. But before we move into the next session, just a couple of reminders. One, for those who may have to duck out before the end of the session, that we do have a short evaluation that we will email to you, because we do like to get feedback on the session to make sure that we're constantly improving and meeting your needs as a network. The next is we will have another TBC at UBC Network event. So the next one is scheduled March 6th, Thursday, March 6th. And the panelists will be the Health Data Coalition Discover team, and looking at how to leverage practice data to improve care. And an invitation will be sent to those network members who have signed up. So if you're not currently signed up as part of the network officially, please do so, and Aoife will post a link in the chat. And the other piece is, so we're going to do breakout rooms for 15 to or 20 minutes, 50 minutes or so, and then we're going to come back. And for those who can stay, we're going to sort of wrap up, feedback some of the breakout rooms, and then talk about any questions that are generated and things like that. So if you do have the opportunity to stay between 1 and 1:30, that's great. We'll continue the discussion. So without further ado, let's get you to your breakout rooms. To join a breakout room, hover over the 4 squares in your Zoom controls, and they should provide you with the list of breakout rooms. Click join, and then confirm by clicking join. And Mac users, you need to hover over the number beside the breakout room that you want to join. And yeah, and then we'll draw you all back. So 1, 2, 3, go.
Welcome back, everybody. It was great to hear so many thoughtful ideas in my group. And just keeping an eye on the time, I want to thank everyone for joining us today, recognizing that likely some people do have to leave as we approach 1 o'clock, but that we will continue here for another half an hour and talk about the conversation that came up in our small group rooms, and then continue the conversation as a larger group here now. I wonder if I can invite the facilitators to share some highlights from each of the groups. Maybe I'll give folks a moment just to organize their notes and share just a couple of highlights from my group. And then somebody can pick up after me. I was with Christy with a couple of people. We had a nice small intimate group in the practice, looking at the practice arena, and talked about collaboration and how we might support and enhance collaboration that supports both patient care and development of learners. And I think the take home, one of the folks in our group raised a really great question. And I love beautiful questions. And we were talking about a particular challenge with perinatal care, and the movement of people further away from the healthcare system, and the kind of increasing either distrust or skepticism. And the question was, how do we relate or connect people moving away from the medical system and foster a culture through team-based care and through health teams that is supportive, humble, and maybe moves beyond anticipated health professions? So with respect to perinatal care, talking about doulas or Indigenous health workers. And there was some discussion around some work in Victoria that is beginning with the communities, and the clinic itself is being designed and operated by community members. And how might that change things? And that was a lot of the conversation in our group. I'll invite another facilitator to share.
Sure. I'd be happy to.
Clayton.
I'm going to see if I can pull up the whiteboard that we had. I don't know if people can read that. It's pretty small print. Yeah, I think it's interesting how the themes overlap that are a little bit different when we're talking about practice. We had a bit of a discussion looking at the demands for patient care and how that can take away from education and vice versa. But I think that more interesting sort of the direction that we went was to talk about who might be other team members that we need to consider in 2.0 that would be involved in care and in education. And one of the suggestions had come up about what about the MOAs within the clinic and what kind of education do they provide and how much time at one particular practice they might actually have the residents spend time or the learners spend time for an afternoon, say, with the MOA and just seeing what they do, which is really kind of interesting. and that was from Elkview Clinic. The other was looking at what about those team members who are not geographically based where the learners are, and what are the challenges that you find with that? And some options are to bring those non-geographically located members into the clinic for a period of time, but also getting innovative and looking at things like texting relationships and texting educational relationships and virtual relationships that they can have with those team members between them and the various learners that they had. I think probably those would be the things I would highlight in the short period of time that we have here. I'm going to try and sort out this whiteboard a little bit more and just have it so that it's a little more cohesive for future reference, though. Thank you.
Thanks, Clayton.
So Lee, I can jump in if you like.
Excellent. Thanks, Josh.
We were the group 4. Jackie and I sort of corralled a dynamic conversation that crossed all sorts of interesting things around the learning environment. And I think the big message that we started with was what are the challenges? And one of the challenges was space, and had a really good conversation, like physical space, like how do I put learners into my actual space? Are there rooms and offices? And had some fantastic dynamic, conversations around layering learners in, art residents in their second year with medical students in their third year, having them work together, really building not only the opportunity for virtual care, but making it so much like you still are together in a common space so that you can learn from each other. There's cross-pollination of the learners alongside the preceptors. But then if you have to move out into a separate area because of the noise, what that does to the culture, which then led us to a really interesting conversation around, well, what sort of solutions do you have to that across some of our TPCLCs? And the real big point of emphasis was around connection, was around making sure that you're creating space for connection and conversation that isn't just about you need to learn this particular problem, from a diagnostic perspective, but how you actually learn from each other, how different modalities learn from each other. And it creates the connection where you get to learn about the medicine or about medicine in general, but also like, where do you park your car and how do you build a culture of accountability to one another, and what's the password and where do you eat and what kind of groceries do you get when you're in one of these places across the province. And so really some of the innovative ideas about how you build a community of practice within your practice, how you build culture. And one of our clinicians talked about, he takes his residents or students out into the homeless encampments or the unhoused encampments, where now you have the opportunity to sort of demystify some of the medicine by taking the space conversation away. I thought that was really revelatory as far as we talk about a clinic, but all of us know that we do work outside of our clinics. And it was a really dynamic conversation about the learning environment from the person's perspective, preceptors and that, but then also the actual physical space and the community. Jackie, what did I miss there? Do you want to jump in and share?
No, but as somebody who's actually studied space and the interaction that people have with it, I would describe it as Henri Lefebvre, I think, did, which is referred to as the third space. It's like it's that space that's outside the clinic where the patient's reality is. And understanding that space, it was like exercises that we did at the Abbotsford Family Practice Residency Program, where I took them actually to a palliative care environment so they could actually see where, when they said, oh, I'm going to go visit this patient and the caregivers in that home, what did it actually look like? What did that care facility look like? And they're also very different. As we know, LTRs can look very different from one another, same as palliative environments. So I think it's really important for them to wrap their heads around that context, the services performed, and how that patient and caregivers experience that environment. So thanks, Josh, for that synthesis. That was fantastic.
I'll talk to the research planning group. So Penny and I led that group. We had quite an eclectic group of participants representing business, clinicians in a TPCLC, development office, UBC Health, research, primary care division. So a nice group and perspectives. Talked a little bit about what TPCLC is versus what it's not. So an educational initiative, looking at educational outcomes. Obviously, there are important outcomes from the health perspective, from the cost perspective. that potential stakeholders and as well as funders would be interested in, and that provides an opportunity for collaboration. So Penny and I asked the question for the group to share their thoughts about what opportunities they saw for research and evaluation and collaboration. So those started to flow freely, and certainly we're well built for that. The fact that I see, and we all, I think, agree that we have a hub and spoke effect of a living lab within Gateway, and then the distributed sites within the TPCLC being those nodes out in the field that can gather information and test. So that's a great opportunity. I'm getting in the chat specific research activities that we could look at. One is some of our sites are having co-located clinicians and preceptors, and others are not, so more of a networked or clustered environment. Could we compare those in terms of the outcomes and understand what is working, what's not, and maybe do some quick step adaptation and pivot to ensure that we get consistency? Another might be looking at the models of funding for the different clinics, and in some way, are they different as well? So there's more coming. So I think what we found is that there's definitely interest in and support for collaboration, building out of what we have in terms of other opportunities beyond the educational experience, which is incredibly important, obviously, and certainly set up for success in terms of with 2.0 funding, being able to leverage the effect of what Gateway is looking to do and testing new models of education. Penny, didn't have the whiteboard plate and I need to know how to get that, but Penny, what did I miss?
Nothing. I think that was a really good summary.
Okay, thanks, Penny.
Okay, so I think that's all of the groups. Did anybody else have something that came up in their breakout that wasn't mentioned? I know we asked the facilitators to speak, but now is an opportunity. If you, you know, as Lee says, she loves questions. So I've heard, how do you create that culture? How do you figure out space? How do you engage communities? How do you shift and engage outside of Western traditional medicine? Barb.
Thanks. This did come up in I was in the one research group, but the space issue was looked at in the Foothills Hospital. I know one of my PhD students worked on the ward for the 21st century, and they put observational spaces into the clinics in the Foothills area. Have you guys looked at that space model? And so all of the technical systems people can work alongside all of these projects. Is that something you're looking at as well for the education?
We haven't looked at that model, Barb, but that sounds really interesting. So it's the observation space is integrated into the care provision space.
Yeah. Yeah, so it begins to solve some of those space problems. And so they've dealt with those different areas of practice for the different specialties. And so they'll have some of those patterns laid out. So I'm happy to give you an introduction to that. And I know I also did a research study with some of the different spaces around the world to compare some of them. So I'm happy, but I know the one in Calgary is world class. But really, that's always the issue is how do we fit all these things together, right? And do it in an effective way.
That sounds great.
We
Okay.
can't wait to purpose build team-based care facilities, right?
Yeah.
And it's how do we retrofit?
Yeah.
I know leveraging technology, right? As I think Josh was alluding to, is that concept of some people are present and some people are virtual, and how do you leverage that and then also create that connection if you're not all virtual or all present. So
Yeah.
Any other
Yeah,
question?
I was gonna say, Ian, you might want to bring up too, like, so you create a space, right, for collaboration as you have there, and then, things change, right? And you start to deliver virtual care or use the space for another purpose, and then that conversation becomes more of a conflict because other people are trying to focus on other things. Did you want to bring that up, Ian?
Sure. Christy built the space when she designed the clinic many, many years back. But the issue for others is we have a large central room that has worked quite well because all the preceptors, we usually have more than one preceptor and usually have 2 to 5 or 6 learners at the same time, and they're all in the same room spread out at their own computer. Then the pandemic, and it led to lots of great collaboration, crosstalk, and efficiencies, etc. And then the pandemic came and we were doing virtual care, which we're still doing to a degree. And we do our virtual care from the clinic because it's mixed of patients who are coming in and then patients who are not coming in during the day. And about 30% are virtual. And it's noisy now in the middle room and people are laughing and talking and people are on the phone with a patient about a sensitive issue. And so now the learners are dispersing into the exam rooms that aren't being used for those phone calls and they're all separated again. And so I mean, some solutions are headsets, which could, also with noise canceling maybe on the microphones. I mean, we haven't gone there yet. We have some headsets, but we've had to kind of start to think about what does this look like now with people sort of in collaborating together and then separating and then sometimes they just we don't see them as much, I guess. The other advantage, I guess, of them being in the middle room and being on the phones, we get to hear them talking to patients as well, and it's a form of observation in the way that they interact with patients, at least one end of the conversation.
Christy, if I could build on that, one of the privileges I've had as a preceptor coach is I've had the opportunity to go to, I think it's about 2/3 of the TPCLCs now, and seeing the variety of contexts and how you do have these huge purpose-built kind of centers, but a lot of these practices are, if the residents weren't there, they would just be standard family medicine practices or primary care practices with their space constraints and various constraints. But it's interesting to watch how they do hacks to try and make things work. And I think one of the key things we need to do is figure out how we can share these hacks. And the one thing I'll exemplify is at one of the clinics in Chilliwack, somebody had put a little Velcro piece on the wall and taken a iPad and just Velcroed it to the wall and would link that up via Zoom to her computer in the other office so she could do direct obs. It was like brilliant. It's simple. And she could do it any other room wherever the Velcro would go. And those are the types of ideas that we should start to nurture at ground level because there's a lot of clever people out there who have some really interesting ideas.
Thanks, Clayton. Mark, go ahead.
Yeah, that's really cool. I mean, I think one of the challenges is, with the TPCLC, we were really hoping to bring along clinics into team-based care that would previously, not have had teams present in their clinical care provisions. So we were actively looking for clinics that were pretty early in that kind of journey. But I think one of the challenges in reaching out, and Christy nailed it with the term retrofitting. When you have small to medium-sized, community-sized clinics, typically what happens if space develops, if you have an empty seat, then it gets filled with somebody who can pay overhead. It doesn't get filled by somebody else who's not contributing to the cost defrayment of the clinic. So I think that's an area for innovation as well with kind of the funding that we receive as clinicians. I know there are incentives out there, but most of the incentives relate to the actual hiring of the individual as opposed to how you're going to provide a decent workspace and environment for that individual. And I think that funding piece, if we're hoping that team-based care is going to be not a luxury, but something that's provided by all primary care providers, then we're going to have to look at that funding piece as well.
Yeah, thanks, Mark. I know that that's impacted the ability at the UBC TPCLC to integrate some professions. Any other questions that came up, or do you have any gap? So So we had a great presentation, and you've got a sense of what the project is, 1.0, 1.5, and aspirations for 2.0. Any clarifications that you were hoping for? Guys did
I
a
think
great job.
John is talking, but he's muted.
John may be supervising a resident at the same time as attending.
No, Dr. Chan is actually right across from me. We're in the lunchroom together. So we're having this a bit of a side conversation based on what was discussed about equipment. I'm just wondering if there's options for hardware upgrades. Sorry for the distraction.
Um, that's okay. Barb, go ahead.
Thanks. I'll jump in before Jackie. One of the things that I think is really important for your group is how you're going to prioritize the people who come forward and make the requests. So I heard you guys saying that you had people who are lined up to enter. And so I know I'm going to go and recommend this to some of the groups that I know. So I guess I'm interested, is there ways or areas that you're looking and gaps you're looking to fill? That would help me.
Mark, I can
Yeah.
jump in.
Yeah, that's really exciting, Barb. There's definitely in the presentation we said our expectation is we're going to roll over most of the clinics. We will have an application process for becoming part of 2.0. And if it's a 1.0 clinic, then part of that application is a review of how adherence to the model has gone over the last 3 years before that clinic gets rolled over. But in the main, we think we'll roll over most of our clinics. We had northern communities as a priority. We really wanted to make sure that we were able to expand into that area of the province, and so we've done advanced meetings with 2 clinics. And one thing that is really, really helpful is they've already got the space issue sorted out. They've already got the a very robust team-based care provided. So I think those folks will be pretty much a slam dunk. We're also really interested in discussion with Indigenous community leadership. Well, but very much aware of the fact that we don't want to kind of present something that folks don't think is helpful. So we want to make sure that we have an opportunity to explain what our project's about, and if that's helpful in any regard to what they're trying to do in their communities, then that would be just great if we could find a way to partner with what's going on there. I think when we've received applications in the past for 1.0, we've looked at the track record in terms of teaching. The majority of our clinics that were brought into the project had already experience with postgrad teaching, but we did have one clinic in particular that had pretty much been exclusively undergrad teaching, and we did a bit of an audit and an assay of what the evaluations had looked like, and it was very clear that this was a very strong teaching clinic, and so that was exciting, being able to move postgrad into there as well. Of course, with the understanding that we weren't going to displace what teaching was happening there. So when we've reviewed clinics with 1.0, and we had, I would say for every clinic in the project, we probably had, and I think this is a success of the project, we probably had at least as many that didn't end up signing up, either didn't sort of didn't feel that what we were providing was adequate for what we were asking, or didn't meet the kind of criteria we were setting up. And so we thought that was a success, because we wanted to make sure that the vast majority of teaching that was happening in our program was not feeling disenfranchised by what we were doing, but actually feeling helped. And so the basic criteria is teaching experience, the robustness or not of the team-based care that's already happening. And then I think the other criteria that's a bit different this time around is that geographic prioritization of the North and Indigenous communities, if that's something that Indigenous communities themselves want. But we've we've had 2 clinics apart from the North come forward, one on the island and one on the Lower Mainland. We love meeting people, so yeah.
Thanks, Mark. Sarah Fletcher asks in the chat about a plan for standardized onboarding if there's a 2.0.
It's a great idea.
Thank you for that suggestion.
thanks, Sarah. Yeah, it wasn't on our. I mean, the thing we're really excited about 2.0, but we're kind of caught in limbo because we still haven't had the funding confirmed yet. And we're very optimistic and hopeful, and I think we feel that we're right to feel that way. But before we kind of move forward with 2.0, we really want to make sure that that funding's in place for July. But that's a really good point. I think that's an area, and I can't speak if that's come up with Penny's evaluation, but I think having some kind of standardized onboarding is a great idea.
Yeah, I mean, we created a faculty development program for a cohort. And if it's a new cohort, do you restart that faculty development program, for example, with the team mapping exercise and the learner pathway exercise, in addition to integrating new preceptors into the community of practice and those opportunities? Josh, I see your hand.
Yeah, I'll just add that I think that is a great idea. We need to learn from that from the TPCLC, but it also expands to beyond. So to the greater core program or to our enhanced skills program, what it is to onboard a clinic, a community, a site, an expansion, both from the resident or the learner facing side. What do you need to know about, parking and groceries and whatever else, which is part of what we've learned, but also how do you create this culture that is in fact different than your typical one-on-one, more service-oriented learning environment. And so I think it has greater implications than just the TPCLC onboarding, which is where I've been so encouraged to see some of the growth, innovation, and learnings from our site.
Thanks, Josh. Mark, go ahead.
Yeah, I just realized that there was one other thing I should have added in my answer to Barb's question, which is having some kind of pre-existing relationship with a postgrad teaching site in that area or region is a definite plus, because once we engage these clinics, we have to have residents to supply them, and we have to have a site, and we've got Josh, correct me if I'm wrong, but I think it's 22 sites now all over the province.
23 regular sites and 40 rural training sites for the largest program in the country. Again, just bragging.
So yeah, I mean, we need, if a clinic has already got some connection with one of those nodes, then we know that the residents will have the adequate support and the faculty and preceptors as well. So that's definitely a plus. But having said that, we did have a couple of clinics reach out that did not have that postgrad relationship, and that was an opportunity to find more preceptors for postgrad, and that was a real positive. So clinics have been taken on board that don't have that existing relationship but have got a teaching history. But we just have to kind of make sure that we're able to kind of match them up with the appropriate supporting site.
And I imagine for 2.0, it's also developing those relationships with regional post-secondary institutions that have other healthcare provider programs. While UBC has some distributed health professional programming across the regions, it does not have nursing, for example. There are 17 post-secondary nursing schools, I think. So those connections as well, I think, for 2.0, definitely key. Okay, it is 1:25, and I want to thank you again. It's been really a great conversation. And I really want to thank the panelists and the facilitators for sharing the project. We'll all keep our fingers and toes crossed for 2.0, and perhaps have you back to the network to give us a follow-up. I want to thank everyone for participating and hanging in for the breakout rooms and the large group wrap-up and conversation. There are a couple of events coming up that you might be interested in from UBC Health as well. One is we've opened the looking at abstracts for a conference that UBC Health is supporting, and it's called Where is the Patient's Voice? And it's taking place from November 12th to 15th. But the abstract submissions are now open, and we should have the link in the chat. And then another UBC Health event that's coming up. It's a day and a half called Bridging Research and Action. It's May 15th and 16th. And this event will be taking place both on UBC Vancouver campus and UBC Okanagan campuses. And again, the link for more information on the event. And for those who may have attended the UBC Health System Breathe and Weave event or the cross-sector dialogue Weaving the Threads event, this Bridging Research and Action is a bit of an evolution of those cross-sector connection opportunities. And the last one is, again, March 6th will be the next TBC at UBC Network event with our HDC panel. And watch out for the evaluation, please, because we really do love to hear feedback from our sessions. And you now have 2-minute bio break before whatever you have scheduled next. Thank you all.
Thanks so much.
Thanks, everyone.
Thank you. Sorry.